Hi, my name is Sandra Allison, and today I'll be showing you how to scan the hand and wrist. Okay, when scanning, we're going to start with the finger, and we're going to start with the flexor tendons. It's important to do the scan with a patient comfortable. I prefer to have the patient sitting across from me with a table in between us, and with a rolled towel or a roll to keep their hand comfortable, and to avoid interference with the table and the transducer. Okay. So I just place the gel on the finger, and I try to localize the flexor tendons. You should see two, which may not be easily distinguished from each other. There's a superficial and a deep tendon. You can flex the finger at the DIP joint to isolate the deep flexor tendon. And you can also use this to evaluate for normal or abnormal tendon sliding motion within the sheath. Okay, and you can scan down towards the insertion of the deep flexor tendon onto the distal phalanx. Here's the insertion shown here. And at this point, we only have one flexor tendon, which is the deep tendon. Scanning up, we start to encounter the superficial flexor tendon, which we should see fully at the level of the proximal phalanx. And here we are now at the metacarpal phalangeal joint with both the superficial and the deep flexor tendons. Now when scanning for the pulleys, we look at the A1 pulley at this level, and you may see it in the long axis as a focal thickening in the flexor tendon sheath. This is much easier to see in the transverse plane. As a halo or a focal thickening around the flexor tendon. Now crossing over the metacarpal phalangeal joint, we see the absence of a halo as there is no pulley in this location. And then distally, we see another thickening which represents the A2 pulley. Now the pulley is only present, the pulley is only present over the proximal portion of the phalanx, where you can see that the tendon to phalanx distance is very little, as opposed to over here where the tendon to phalanx distance is increased because there is no pulley. When you're evaluating for trigger finger, again, you can passively or actively flex the fingers to observe for normal or abnormal tendon sliding within the tendon sheath. And do the other side. Okay. Now we can also evaluate the extensor tendons with the same method. I prefer to start at the level of the metacarpal head, as the tendon is more easily identified. As this thin band. Distally it's thinner, but can still be identified with careful scanning. Now the sagittal bands, so just pull your finger over and bend a little there, are very superficial structures, and it may help to use a standoff pad or heaped up gel. And the bands can be seen as hypoechoic structures that are stabilizing the extensor tendon onto the phalanx. To evaluate for subluxation, you can scan with the patient with the fingers extended and then with a fist formed. You can see that the tendon remains centered on the metacarpal and is not subluxed. Now we can also scan the median nerve, which is the most common nerve affected by an entrapment. And I again like to use a roll or a rolled up towel and have the patient drape their wrist over the roll. The median nerve can be distinguished from the adjacent flexor tendons, which are more echogenic. You can also confirm that these are tendons by rocking the transducer and showing anisotropy. There is some anisotropy with a nerve, though to a lesser degree. The nerve has a distinctive fascicular pattern. And you can see the nerve as it sits in the bony carpal tunnel with the retinaculum extending across. The nerve can be scanned in the transverse plane as distal as possible and as proximal, so you can follow it up the arm. And then, of course, you would evaluate the nerve in the long axis by turning the transducer while scanning the nerve. And again, evaluating it for differences in thickness or appearance. One other thing that you can scan is the ulnar collateral ligament at the metacarpophalangeal joint of the thumb. And you can either have the patient extend their thumb, or you can turn the roll and drape their hand over the roll. And you can place a transducer across the metacarpophalangeal joint to show the ulnar collateral ligament. You can evaluate for laxity in the joint if you suspect a tear by stressing the joint and observing for abnormal increased joint space. That concludes basic evaluation of the hand and wrist with ultrasound. Thank you.